lost my page. Next up, we have our keynote address. Please welcome Dr. Danielle Bouchard, a full professor in the Faculty of Kinesiology at the University of New Brunswick and the co-director of the Cardio-Metabolic Exercise and Lifestyles Lab. Using a mixed methods approach, her research focuses on identifying evidence-informed exercise programs that optimise functional and health outcomes for ageing adults with and without chronic conditions. She currently leads a national grant through to 2029 to improve access to evidence-based exercise programs that reduce falls risk and is a visiting scholar at Monash University working closely with Melanie Farley. Welcome, Danielle.
Okay, hello everybody. It took me about 5 minutes to get used to the accent, so maybe it'll take you 5 minutes to get used to mine. When I was asked to talk to this symposium, I was thinking, like, what do we don't know that people would be actually excited to hear about? Because when we talked about exercise and falls, we sometimes wonder, like, what do we need to know more? Because we've been talking about this forever. So do we know it all? So I'm from New Brunswick, which is a small little dot there in Canada. We're a small province, would be like similar to your states, but in my province, there's only 800,000 people living. And we do great things. We have weird things going on because we're small in size. But I often, like a good researcher of mine, where I followed a lot, told me there's two types of researcher in this world. There's the moles that do the same thing over and over, the same subject, the same thing, same mechanism. And there's the sniffers. So if you are in this room and saying, like, I haven't heard about this Bouchard person and I've been in this world forever, it's because I'm a sniffer. So I go wherever, like, I feel like, and I think there's pros and cons to the two types of researcher, those that are having expertise and those that bring new ways of thinking. And I like to think that I'm the one that comes and shake things up and be like, did you ever thought about this? So that might be the reason why you don't know about me in the falls world. And I think as well that adopting mixed method is probably like the way to go, where like you kind of use the method that is required for your answering your question. When we are a mole, we're more like, I'm a qualitative person, I'm a quantitative person. How about you do both? It's really hard, and mixing them is even harder. But I want to start with that and say, like, we want to answer the question the way that it needs to be answered, no matter what it is. And if you can't do it, learn or get somebody else to do it. Land acknowledgement, like most of us, like, we want to acknowledge this land that we're living on, either working from home or visiting the land. I've been here since January with Monash University, and I've been fortunate enough to work on unceded territories. So what do we know about fall prevention and exercise? And I will focus on community setting. We must know something because there's 12,000 publications on PubMed as of last week. And there's more than 2,500 systematic reviews on the subject. So people think that we don't know. We do know things. But what do we know? What do we do with this knowledge is more so like the question right now. So for knowing, we know. And then what do we know for sure? Or I should say for sure, meaning that we have a lot of evidence. We know that we need to do quite a lot of exercise. We recommend the best evidence out there would be like 3 hours a week, all year long. Winter is coming here. I'm not too excited to go out. I don't call this winter, but it's a bit colder. So there's barriers and challenges. We need to provide high challenge to balance. So why do we still have chair exercises when our goal is to reduce falls? It kind of bothers me a bit, especially in the community. And all year long and 3 hours a week, this is a lot. And I spoke about this before, and somebody from Sydney told me that they heard me saying that. It's like 5-10 portion of fruit and veggies for your kids. It's hard. There are a lot of barriers, yes. But should we say, like, you know what, I like you so much, I'm tired of like bothering with this, just take 2. 2 will be okay with you. No, we just keep fighting, putting it into whatever like you can to find that, to hide the color. My little guy says, like, the color is for mommy. We have a lot of barriers, and we have a lot of barriers for that too. But when we do these things, we reduce by 49% the risk of fall in the community. And then we get bothered with the numbers. We're always having numbers, and numbers don't mean much when you don't put into context. So if you do all of this, and you tell your grandma, you're going to do all of this, and you're going to have half of the chance to fall. That doesn't seem like, it seems like a lot of work to have half. But if you talk about the consequences of falling, the main reason why people get to the ER is because of a fall. The main reason why they don't go back home after a visit at the ER is because of a fall. The main reason why they have a hip fracture is because of a fall. And the reason why they die in the next year after having an injury is because of a fall. And the consequences make this number really more important. And another thing, too, that I find really interesting is when you put into context, we're ready to do physical activity to reduce our risk of cancer. We're ready to stop smoking to reduce our risk of cardiovascular disease. And then we're ready to do like the veggies and the sleeping well. Like it's something that we hear a lot, but those are not reducing the amount of risk as much as the 49% for doing exercise and reducing your risk of falls. And then when you do pick the right exercises, that 49% can even be higher. So putting things in perspective, there's a lot of lifestyle changes that people do to avoid different things, but 49% is quite a lot compared to the other things that you think, because you're only reducing your risk. People think, if I'm active, I don't get cardiovascular disease. No, you're reducing your risk. And in this case, 49%. When a colleague of mine did look into like these guidelines, and then all the community, there's a lot of community programs that exist in society because of that 49% and because of the aging population. But if you were to look in Australia, because I haven't seen the data, how many, if you put it in percentage, how many community programs do follow those guidelines? Not people doing it, the organization focusing on those three elements, and then say, I'm going to offer all year long, I'm going to offer challenging to balance, and I'm going to like do it, offer it 3 hours a week. People come or not, that's different, but how many? In Canada, we did the math, and we did the scan, and we did all the research with it, and it's 6%. 6% of community programs in Canada do reach those guidelines. But the funny or interesting part that I find is that they say, all of them almost say, one of the criteria that they meet is challenging balance. But when we ask, how do you measure if you challenge balance? It's like silent radio. We don't know how we know that. We just feel that if you do exercise, you must have been challenged at some point. But we don't know. So we know if you offer all year long. You know if you did 3 hours a week. That's measurable. But when it comes to like challenging balance, I'm hoping so. I'm thinking so. Like I probably do. So that's a hard one. Another thing that we know, and that was a good paper, you might have seen it pass a few years ago, where there's so many exercises you can do with seniors. Are you going to concentrate on resistance training? Are you going to concentrate on like walking, yoga, tai chi, name it? They did put together like 63 different combinations that were done like with a network analysis that is like comparing different things at different moments in an analysis. And you know what is important for seniors when it comes to like the right combination? It's not named with an activity. It's not Tai Chi, and it's not Zumba, and it's not yoga. It's what you do in these activities. So it seems that the best combination out there for exercise would be the combination of those 5 things. So anticipatory control, I can't say that word. It shifts one center of gravity. So like you would shift your center of gravity, which is probably something that you do without noticing in most of your exercise. Reactive control is a hard one. So that would be like you're challenging your blood, you're getting disrupted, and you have to get back your balance. We tend not to do that because, oh my, like they would fall if you do that, right? But that's a part of the best mix. Dynamic stability is another one. So maintain your one balance when you change your support. So the one leg stance would be an example of that. Functional stability, like having a lot of reach to a point where you actually might get too far, is another element. And the last one is flexibility. So the interesting part is there's no resistance training. And per se, like there's nothing about strength that came out to be significant. If you look at the paper in detail, you'll realize that resistance training was part of that. It was just not part of the best mix. If you do all of this, you're reducing your risk of falling by 86%. So we're going from 49% to now 86%. But you have to keep in mind that when you work with seniors, you're afraid of them falling on you. Like so when you do those exercises, having these activities can be useful, but if you do them too far, then you're increasing the risk of falling. So because of safety and liability, which is like a big problem, you will get them sitting in their chair and having the social part of the exercise, which is good, but it probably won't reduce their risk of fall. Another thing that we know that's been controversial in the last couple of years is how do we know which person is in what bucket? So like, are you low risk? So we're primary prevention, you don't fall, but we want to make sure that you're not falling. Moderate, which would be intermediate, I guess here, those three. You have fallen once in the last year and you have some complication. And the high risk would be if you are falling more than twice in the last year and you had complication. So by doing these buckets, we're starting a big conversation about it. But what it does really well, though, is telling us like maybe we don't need an exercise professional with whatever titles for all of these three buckets. So back in Canada, I work a lot with communities, municipalities, to say, how can we get people that are considered being a low risk and have activities that are challenging their balance and reducing their risk of falls, maybe without a health professional. And that's really challenging when it comes to liability. There is like more than 5 billion people on this planet, and most of them are not active enough, including us. So if we need a health professional to get people moving for all the people, we're not enough. So maybe we need to like think about how we use our resource to be involved with the moderate and the high risk and leave the low risk to non-professionals that can get the primary prevention being done. I'm just throwing it out there. So that's what we know, and that's what I think I know, and that's what I'm pushing for when it comes to like what should we do in community. We should try to get to the guidelines. That's my go-to. And what we don't know is how to attract underserved communities. And we were talking about a PhD student working on this. This is great. All the data that we have is on mostly white Caucasian women. So we don't even know if different communities should follow the same guidelines. Well, we can't get them there anyway. Most of the programs, I oversee a program that has about 25,000 people. And in there's only 12% that are not Caucasian and about 16% that are male. So we're not doing a good job to attract underserved communities, and male being an underserved community in this case, which is a bit hard to sell as well. We don't know what are the barriers to community partners to offer 3 hours a week. And we never said it had to be in person. Well, it's hard because my room is only available twice a week. Great. There's so many remote ways that you can get people, especially in the primary prevention sphere, those that don't have issues yet. How do you do it? To offer all year long. Back home, summer is June to August. And they're like, well, nobody will come and exercise in June and August. When you ask older adults, when you involve you call them consumers here, they tell you that, you know what, at 72, I prefer doing stuff in the summer and then actually having a break or vacation when nobody is using those facilities, right? Like in Asian communities back on the West Coast in Canada will say, well, this is not summer. A bit like I say, there's no winter here. For them, like summer in Canada, it's pretty mild. It's time to do exercise. So it's really important that if we want to do anything about that in the community, to understand the barriers from their perspective. What are the effective strategies to change practice? So like we know there's a lot of programs out there that are not following best evidence. How do we change that? That's hard. We have a program. I'm sure you have programs in mind. They've been running and funded for 20 years. And then now you're showing up and say like, what you've been doing is not optimal. That's how I sell it. We're not saying this is not good. We're just saying that you could optimize what you're doing with this community by finding facilitators to get to the guidelines. And then we don't know how to sustain a successful community program. You all know about programs that existed. They're really well done, really well attended, but then funding is lacking. And then we're going to find new funding for a new program. So we start with the Sunshine program, and then we go to the Winter program and do whatever the funding comes with. There's nobody, I think, like raise your hand those that know about the Otago program, right? Many people know about the Otago program, and I could ask this question in all across the globe, and I'll have the same answer. Why do we know so much about Otago program? Is it that perfect? Is that exciting? Is that great? No, but we all know about it. So what we do right now is we're trying to understand what they did, why. Like if it would be the excellent program and if it would be like the best thing we can do. They did something magical that 20 years down the road, still people know about the program and implement it. It's good in some contexts for sure. So we have a program, we got funding from the CIHR, which is the National Health Research Council in Canada, to do some of that work. And it's not about proving that when you do exercise, you're reducing falls. If you come to ask money for this, they'll turn you away. We know this works, but we don't know how to attract people that are not currently coming. We don't know how to adapt the program that exists, have funding, but are not doing the right thing. We don't know how to implement program from one place to the other that are actually well done. So it'd be nice if you have a package somewhere that you can actually bring to other settings and it still works, but we don't really know how to do that. And the sustained part that I said, like when something really works, what are the strategies to keep it working? So this is what we've been working on, and I'll go pretty quickly on this. If you are interested in the sense that even though we've done work in Canada, we have collaboration across the globe, and if you have a program that you would want to adapt or find ways to attract or implement something that is new, if you want a package that is all done, or you want to find ways to sustain a program that exists in your community, you can communicate with me and we can use some of our funding in Canada to help you do that, because it doesn't matter really where you are. If you find strategies, it should be useful for others to know about it. So we've been doing some different things with ADAPT. And so like if you have a program that exists, some of the strategy we had to like have the 3 hours a week. So the first one on the left might be a logo that you know is coming from Australia, like it's the Standing Tall app, been developed in Sydney. And we're trying to get people to see, if you come once a week in our program, can you add to what you do on your own, either by the Standing Tall. The Move 50 Plus is a pre-recorded video that people can follow. We have our program that is live, and also we have, if you want to, your program is great, offering all year long, 3 hours a week, but you don't challenge balance after we actually look at your program, then maybe you can get some information about the balance intensity scale that was developed by Dr. Farley and her group here at Monash. And all of this is making programs more likely to follow guidelines and eventually less likely to fall. So there's different ways that we can spice up the program that exists already. It's not about revamping the whole program. It's about like knowing what the best science is out there and then trying to adapt it. And I'll go quickly on this because I got my little note here. Yeah. So there's many opportunities that exist across the globe, and then you're lucky because you're Anglophone. That's the first language we do everything, and then we translate if we can. So there's no reason why Anglophone countries cannot take the literature as it is and make good tools for clinicians. So we did two here, and we're not really good at knowledge transfer to go from the science to the clinics, but what we've done is an exercise inventory. So an exercise inventory is like I talked about those 5 elements: anticipatory control, reactive control. Clinicians ask us like, so how do I apply that? What activity do I do? So we did create like a 50 different activities that you could do and progress people to have a meaningful challenge their balance. If you're interested in having that, you can communicate with me. This is free. It should always be free, I think, to get some of the data. And then we have on the left side here, like something that to help people that offer exercise programs, like how do you structure your class? So if you look at the middle part, main exercises, that's where like you have your activities that would challenge your balance. And you're like, you talked about strength training not being there, and the first thing is bicep curl. Yeah, we do bicep curl on 1 foot, and we don't have weights. The goal is not to increase strength here, but it's to challenge balance, and why not use the bicep curl anyway? One thing that I should say too, like we challenge balance by removing or reducing the base of support, but also eyes closed. If anybody stand up on their feet and we close your eyes, you'll be challenged. It doesn't matter who you are, but we often not want to do it because we're so afraid they will fall. There's ways you can challenge balance without having a fall, and that's where we're super afraid of doing because of the consequence that we could have. We're trying to prevent something and we make it worse. So what is needed in this field? We've done a lot of work on like knowing what is actually working, but we're not really good to like understand how to make the thing work. So I will go here and say like we need to like, and then some people talked about implementation science. We need to know how to use what we know better. How do we get things that we know to actually be useful? And that's like the new area of like spinning on the implementation science. And so we need to know like how much and how well we do things. That's really where we are. And I'll encourage everybody to think about like when you are looking at novelty in this world, I believe that the answer is in the hybrid model. Hybrid model meaning that you're collecting data. Here, like that's what we've been doing a lot. Effectiveness. What you do is working. What you do is working great. And then the last line in your paper is clinicians should. Oh my, they never read this paper. How would they should do anything of that? So the last one is what we're like aiming for most of the time now, where we still validate what we do. Like we'll do like a randomized trial with it, but we will have a lot of implementation outcome. Like, do you reach anybody? Do you change practice? This is more the outcome that we're looking for in the world of falls and exercise right now. So I was told it's on time. So when it comes to fall and exercise, I said like we all know and we know it all, right? Well, we know well what, but we need to work on the how. And I'll stop here. And if you have any questions or you want to reach me for the AIMS program, you can also communicate with my coordinator, Marco. But I'll be around all day if you have any questions.
I'd like to know how you can get to some cohorts of people like polio survivors who are falling over with monotonous regularity. How do we retrain them? And how do we turn off the noise?
Yeah. That's my strategy, is not to have questions. Planned it.
We'll use that microphone, thanks.
Okay.
Okay, the question is like, how do you reach different population?
Yes, I mean, there are cohorts out there that are problematic communities.
Yeah.
I am one of them in the post-polio community, and we are hidden under the blankets and all the rest of it, like plastic. How would you get to it? You know, is it a slip, slop and slap? You probably don't know what slip, slop and slap is. An ad we had here in Australia, Stop Us Dying of Skin Cancer. They came up with a great television ad, there's probably not a kid in the country that doesn't know about slip, slop and slap.
Yep.
This to me seems to be something that needs to be, forget the health professionals, John and Josephine Simpson don't know.
Yeah. So, I mean, luckily, I think in our days, like where seniors get their information most, in Canada anyway, is with social media. And that spreads a lot fast. And we're talking about like Facebook. My students are saying like, what is Facebook now? Like, it's an old generation social media. That's how I define it now. Because anybody like below age 30, like you wouldn't use Facebook unless it's an active. Like that, my kids will tell me like you can use it, but only in this case. So I tell my kids I don't use it, but I go every day. It's the social media really helped because you can spread like the advertisement for these types of program in the groups that you trust. Right? Like it's not about like a university that promotes whatever or a community that promotes whatever. It's like the activity, like the program or the opportunity is made of a little PDF, and it can be spread within the group that you trust. So we that, and also like we have a lot of consumer committees where we have people that are inserted in different small groups. and then they get the information from them. Because one thing that we realize, especially with Indigenous communities, it's all about trust. So even if I would go to you or a group, like you might not feel that it is understanding the condition or the barriers that you have to do these types of activities. So it's built with trust, and then that comes from consumers, communities, but also like social media that you trust. And not like, so for us, their work is to put the advertisements, so groups endorse it, and that's how it starts. Yes.
I'll talk very loudly. Maybe you might need to repeat it to the people online.
I'll try.
What is the reaction of clinicians when you come to them and say, you could be optimising this program you've been providing for 20 years and do things a bit differently? What is the reaction?
So the question is like, what's the reaction of clinician when you say like you maybe should adapt what you've been doing for 20 years? Not really great in a sense, because you have to be part of them. So I'm an exercise physiologist, so going to physio, like it's a bit interesting. Friction. And that's across the globe, right? It's not the same, it's the same here and it is in home. So you have to gain trust. And the way that we've been doing this is showing them that what they do might not be optimal. So by looking at what they are doing, they need to be interested of changing things anyway to start off with, right? Because you're not going to change something that they don't want to change. But the one that we've been fortunate to work with, they need to be convinced that what they do might not be optimal. And the biggest problem we have in exercise science in general is exercise is good for everyone, in any shape or form. So as soon as you do exercise with somebody, that's a win. So why bother with the details? They're showing up. When I took this program that's called Zoomers in Balance, they said, should we invest in this program? I said, what's the goal? And they said, reduce risk of falls. And I said, do you reduce risk of falls? Probably. But they like it. I was like, okay, great, but the government will never fund this. So you have to test what they're doing. I think that's the only way you'll have their trust, is that by saying like, okay, you're saying this program is good for reducing falls. Let's see if it does reduce falls. And then you can make the adaptation. Because to start with, people will estimate their program value based on the number of people that come and come again. If they like it and they come again, why change? Because it's such a barrier to exercise altogether. Like if you change things, like are they going to still come? So the first thing I'd say, like to have the buy-in of clinician, you need to like kind of challenge what they think this program is about. And if it does do what they're supposed to do, then leave them alone. But if it doesn't do what it's supposed to do, like you can compare risk of falls in a year. Another problem that we have to like coming on this is that it's really hard to measure. Falls is a hard thing to measure. It's mostly self-reported. And if you look, if you work in nursing homes, I don't know how you call these institutions here, but nobody wants to report a fall. It's not on their shift. It's not them. Like nobody wants to report a fall. So it's really, really hard. Male, oh, I fell, but it doesn't count. I didn't injured. So it's really, really hard to quantify. So gaining that trust by showing that the program is not making the trick, it's hard because our outcome is hard to measure. So it's tricky. It has to come from them and say like, we've been doing this for 20 years. I'm open to see if it actually is working, but it's not, the door is not open wide. Like it's not, we come like a little slip in the door and hope to have it's tricky. Debunking a program is not easy to do. Yes?
What's your retention rate of like keeping people on a program for a year?
It's funny you ask because I looked at the data yesterday and it's 76%. And it's 76%, and put this into perspective, like this is about 25,000 people that are age 50 plus, the average age is 69, and then they're in the community and their leader is a peer leader. So really, really a different model that we're exploring right now. But their return rate is really good, which makes it challenging to challenge them. Because that's the problem too, right? Like they start doing an exercise program in the community, they're 55, and then suddenly they're 70, and it's the same program with the same person. So like how do we keep challenge this person 15 years after. They get older, but they get accustomed. If you do 3 times a one-leg stands, doing the same activity, the third time you're a bit better. So imagine after 15 years. Yeah. But beside the fact that they're getting older. So that's the challenge with long-term program, is how you keep challenging them. They like it. They do potluck and they enjoy themselves. But are they still reducing their risk of falls optimally? Maybe not.
So we'll have to stop here. Thank you
Yep.
so much. We've had a lovely morning with many thought-provoking things that we will be asking ourselves and our clients that we service. Without taking much more time, I would like to welcome Charlotte McLennan, who comes to us from Sydney. Charlotte is an experienced physiotherapist and health manager and researcher within the Sydney Local Health District and the University of Sydney. Her clinical expertise is in aged care and rehabilitation, and she currently works as a program manager for the Institute of Musculoskeletal Health. Charlotte has a master's in health service management and is nearly completing her PhD, which focuses on understanding, implementing, and evaluating interventions for reducing patient falls in hospitals. Welcome, Charlotte.
Thanks, Hannah, and thanks everyone for having me here. It's a real delight to be able to present to you all today. So I'm going to monitor my timing. I wanted to start with this picture because it reminded me of myself as a clinician when I was working on the acute aged care wards, and I too often felt felt, what can I do? What actually can I do to prevent my patients from falling? And felt driven to the likes of helium balloons at times too. But fortunately, we have come a long way since then, and we actually do now have quite a lot of evidence that we can use and look to implement to guide our practice in the hospitals in terms of trying to reduce the risk of our patients falling. So today I'm going to start by providing an update to a Cochrane review, providing the results for a Cochrane review that we've just completed and is really hot off the press. It was published just this week on Wednesday. That will really highlight some interventions that have the best evidence for reducing falls in hospitals. We're then going to talk about some of the considerations for implementing these interventions, an equally important question, and then finally wrap up with some takeaways. So our 2026 Cochrane review looks at interventions to reduce risk of falling in hospitals, and it's an update of the 2018 review, which at that point was a combined review with residential aged care facilities. But we now know those settings, there's been a rapid increase in the amount of evidence across those settings and an understanding of the distinct differences. And so the review has been separated. I have missed a slide acknowledging the important team that were involved in this review. So it certainly was a team effort from myself. We then had Sue Dyer, Jenny Suan and Tanya Marin from Adelaide. We had Kathy Sherrington, Vanessa Kwok. We had Mel Haley, we had Jeffrey Murray and Ian Cameron, and we had Dylan Neal and Katie Sutcliffe. So a really big team in our review update. And we were looking at trials that were aiming to prevent patients from falling in hospitals. We needed the trials to include an average age of patients of 65, and we excluded trials that included post-stroke or Parkinson's patients because these are addressed in another review. The outcomes we were looking at in our trials was that we wanted the trials to be reporting either number of falls, which is the rate of falls, or the risk of falling, the number of fallers. We also looked at fractures, adverse events and economic outcomes when they were reported, but this was not very often. So for today, what I'm really going to focus on is the impact on falls of these interventions. And so we ended up with 55 trials in our review that were looking at interventions to reduce falls, and 32 of these were new, so a lot more new evidence. Over 100,000 participants across these from across countries and settings, and it is worth acknowledging that many of the trials did have high risk of bias across a number of domains. And so we had our 55 trials of interventions, but then we needed to group the intervention types to make more sense of our results. And as has been done in previous reviews, we used the profane taxonomy to classify the intervention types. And so this is a classification system that can be used for fall prevention interventions across settings to really guide the intervention types. And so in our review, we ended up with intervention categories that are listed here. So we had exercise, medication optimisation, environment, service model change, education, multifactorial and multiple interventions, which I'll talk about, other types of single interventions, and then an any intervention category, which I'll talk about later. And the intervention categories that are in bold here are the intervention types where we had greater than uncertain evidence. And so it's, we've got really strict and rigorous guidelines to guide our conclusions in a Cochrane review, and to have more than uncertain evidence, you really need a number of trials of an intervention type with a significant participant numbers and of good, reasonable, at least reasonable quality. And so these are the intervention types I'm going to present on today. So excitingly, as a physio, for the first time in this review, we were able to make a conclusion around exercise, and that's that exercise may reduce the risk of falling for patients in subacute settings. And so you can see on our forest plot here, we've got our exercise trials in subacute settings down the bottom, and that diamond is to the left of that line of no effect. And so this makes clinical sense too, especially, knowing what we've heard from Danielle, that exercise is an effective fall prevention strategy in the community and in residential aged care. And so in subacute settings, it would stand to reason that there's time for exercise to take effect as a fall prevention strategy. We then move on to service model changes, and this is an intervention type where there's really been a change to a system or a organisation of care in a health setting or on a ward. And so the intervention types in the trials in this intervention category were things like the implementation or the rollout of intentional rounding, changes in models of care, in staffing arrangements, and the implementation of guidelines. And while the intervention types are somewhat diverse in this intervention category, we wanted to pull them to test the effectiveness of the common approach of making that systems level change. And what we found is that it appears effective when there's a system level change targeted at falls reduction. And so you can see we could make the conclusion that service model changes probably reduce the rate of falls in acute hospital settings, and it was specified to acute hospital settings purely because the trials we had of this intervention type were all in acute hospital settings. We then move on to education, which is where we had the strongest evidence in terms of being an effective fall prevention strategy. And so we could conclude that education probably reduces the rate of falls and the risk of falling, specifically in cohorts with intact or mixed cognition. So when there's a group of patients that either have intact or mixed cognition. However, we were uncertain about the effect of education in patients with cognitive impairment. And sorry for the busy forest plots there, but I just wanted to include in case anyone wanted to see them, but they are now available online too. I wanted to talk about a couple of considerations for education, as it does have the strongest evidence, and that's firstly to really emphasise that the trials of education were really multi-component tailored education packages. It's not sort of leaving a flyer about falls risk at a patient's bedside. So, for example, if we think of Anne-Marie Hill's Safe Recovery trial, which had some of the strongest evidence for education, it really provided multimedia, multi-component education for patients. There was also education for staff. And, in some ways there was almost a service model change aspect as well in terms of changes to staffing to allow that education to take place. The majority of trials that contributed data to the education meta-analyses also included a component of patient goal setting. And so it's likely that this is a really important aspect of patient education as a fall prevention intervention too. Alrighty, now moving on to multifactorial interventions. So these are interventions where there's a bundle of interventions, but the bundle changes from patient to patient dependent on the patient risk factors. And so we had 8 trials of this intervention type and could conclude that multifactorial interventions probably reduce the rate of falls and risk of falling. But the evidence wasn't as certain as for education, and you can see with our diamond there that it does just cross that line of no effect. But certainly, an approach that's trending in the right direction. We then have multiple interventions, which are distinct from multifactorial in profane, in that there again is a bundle of interventions that are provided, but patients receive the same bundle regardless of their risk of falling. And so we had 6 trials of multiple interventions in this review, and we didn't pool them because they were vastly different in the types of intervention within that bundle. But we did do a grade certainty assessment on one trial that was a really large trial, over 10,000 participants, De Gennaro's trial out of Italy. And they tested a fall prevention bundle that was a combination of environment modifications around the bedside, the implementation of 2-hour intentional rounding, and medication reviews for patients. And they did have a significant reduction in falls with that approach, so something to consider. The final conclusion we could make from within our Cochrane review was related to work we'd done prior to the review in an intervention component analysis. And I'm not going to go into that because it could be a talk in itself. But essentially, we did some work looking at fall prevention trials and were able to identify three key features that appeared to be associated with successful hospital fall prevention trials. And the features were integration with the local setting, interventions that were responsive to patients' needs and abilities and population characteristics, and patient and family involvement in the interventions. And what was cool was that we could test this theory in our Cochrane review. And so what you can see in the large forest plot up here is at the top we've got any trials of any interventions reporting rate data that had those three features present. And you can see that our diamonds on the left, that there's a significant reduction in falls when that's pooled. Whereas when we look at the trials down the bottom, which are the trials that don't have those features, there's no longer that trend to reduce falls. And so we could conclude that interventions that include integration with the local setting, tailoring to patients' needs and abilities, and engaging patients and family may reduce the rate of falls, regardless of the type of intervention that's actually being rolled out. Okay, so we've got now some hot off the press evidence around the most promising and effective fall prevention interventions in the hospital setting. We're then faced, which is timed well with Danielle's presentation, with an equally, if not more important question of, well, how do we actually get these implemented into practice? And being from Sydney, I needed to include the Sydney Harbour Bridge to fit, the theme of how do we bridge this gap? And so this is really what a lot of my PhD has focused on over the last few years, and so I'm going to talk about some considerations now. We fortunately have other people that are focusing on the importance of implementation in fall prevention as well, and so a couple of key reviews that also really highlight the gaps around implementation include the review from Mel, Haley and the team recently, which really looked at implementation of fall prevention guidelines, and they identified a lot of gaps such as very few trials reporting patient-centred outcomes, less than half reporting falls outcomes, and I think just one used an implementation science framework to guide the rollout. We then have reviews like Denise Spoon et al.'s from the Netherlands that looked at the implementation strategies of fall prevention interventions in hospitals, and really again identified that very few studies were reporting implementation strategies, which was really making it difficult for both clinicians and researchers to be guided in implementation efforts. We then have the field of implementation science, which has a lot of resources, sometimes overwhelmingly so, that can guide us in our implementation efforts. And I'm not going to go into these today, but I just wanted to provide some links on slides in case you want to go back and look into implementation a bit more. But we've got frameworks such as CIFA and IPARIS, which can really help tease out considerations, especially around barriers and enablers to implementing fall prevention interventions, and help guide sort of domains and certain levels to be thinking about barriers and enablers at. We've got behaviour change frameworks such as the COM-B. We then also have resources such as the ERIC taxonomy, the ERIC strategy taxonomy, which guides implementation strategies and helps define exactly what you're doing to support implementation, and tools where you can match barriers and enablers that you've identified to implementing fall prevention interventions with potentially suitable implementation strategies. And so we've been using a lot of that implementation science work in our work, looking at implementing fall prevention interventions in hospital settings. For example, we've done qualitative work where we've interviewed patients and staff to really understand what are the key considerations to implementing fall prevention programs in busy, complex hospital settings. We've also done feasibility studies where we've tested strategies to support the implementation of multifactorial fall prevention interventions, so strategies such as improvement science, training, clinical facilitation and education, and then done further qualitative work to really understand those barriers and enablers. And so that's sort of at a research level, considering implementation, but you can also consider implementation practically at a frontline clinical level. And so one way this may look is firstly considering, well, in my context, what's the most appropriate intervention that can reduce the risk of patients falling in this context? It's then thinking about, well, what makes this challenging to provide, or what do we have already in place that could help provide this? And it's at this point, and in the one before, that you really need to be seeking input from as many people who are involved in that intervention and implementation as possible. So those delivering it, those receiving it, those managing it. And then it's looking at what could we put in place to address some of those challenges or make use of the opportunities. And so an example, a simplified one but a real one from a ward I've been working with recently, an acute aged care ward, average age of patients 85 and above, and the majority have either dementia or delirium. And so multifactorial interventions is really where they're focusing on their approach. They're keen to enhance these, but have realised when talking to staff, there's a mood around, well, falls are just going to happen. There's nothing we can do anymore. And there's a desensitization to impact. The CNE said the staff care more about the IMS, the incident report, than the impact of the patients on the patients. And so what this ward have done is put together this case study education. And so this is a really great resource that anyone can get, the Mrs. Dean story on YouTube, that really tells a real life story of a fall in hospital and its consequences. And so that's what they've rolled out. The process is iterative and is ongoing. So this is just one example that will feed into the next. And this approach to fall prevention is what we're testing at scale in Sydney Local Health District in the Protect Fall Prevention program, which I've run out of time to go into, but you can read more about in our protocol. And so to conclude, the key takeaways: reducing falls in hospitals is hard. I know that, but it's not impossible, so let's take on the challenge. We have interventions that have effectiveness and evidence behind them, including education, multi-component, service model change and exercise. All interventions should look to integrate locally, tailor to patients' needs and abilities, and engage patients or families. And where possible, consider and address any barriers and enablers to enhance implementation. Thank you. Sorry, bit over time.
Thank you, Charlotte. We're going to break now for morning tea. We're going to save questions